First.
Okay, so this is being
Hi,
recorded.
welcome to our webinar, and this is Dr. Liew going to speak on obstructive sleep apnea. Okay, go ahead.
Okay, right. Thanks, Dr. Betty. So I'd like to say good evening to everybody, and thanks to Beating Hearts for giving me a chance to share a little bit about something that I feel fairly passionate about, obstructive sleep apnea. I think it's fairly relevant to the platform as well. So just a little bit of background. I'm an ENT surgeon working primarily in Beacon Hospital, and so being in Beacon Hospital, a lot of the work is do a lot of cancer-related work, general ENT, but my own interest is actually in rhinology, nasal tumors, and also I've had some degree of snoring and sleep apnea surgery training in Singapore. So just an overview of today's talk. So just a little bit of introduction about OSA itself, one very quick definition and a little bit about some statistics. We'll talk a bit about the mechanism and how it happens, and then of course the social and medical consequences, which are of course of importance to everybody. And then I'd like to touch on the assessment and how we actually take a history and what risk factors and examination we're looking for in patients who potentially have OSA, and then how we investigate them. And then just briefly touch on and give everybody an idea of what we do in terms of treatment and adjuncts for treatment of obstructive sleep apnea. So sort of a general overview of the topic. And
sorry,
yeah, okay.
There are a lot of people who are not on mute, so it's a bit. There's a lot of interference. Okay, you can go ahead.
I think you can continue now.
Yeah, that's right.
Okay, yeah. So we'll touch on most aspects generally on the topic. Most of the information will apply to adult OSA. There will be a little bit of information about pediatric OSA, but I think it's a topic which can be covered at a separate time for anybody who has an interest in it. Right, so start first with what exactly is OSA. So it's obstructive sleep apnea. So the definition bit, of course, it's a syndrome of upper airway dysfunction during sleep characterized by snoring and increased respiratory effort, secondary to greater upper airway resistance and pharyngeal collapsibility. So as the name itself states, it's something which only happens when the patient's asleep. It involves either full obstruction, as in the blockage of the airway, or a partial collapse, which increases the respiratory effort. Okay, so the people who are familiar with it, it looks a bit like this. Yeah, so so for people who have partners or family members who have an experience with this kind of thing, they'll know that obviously it can be quite disruptive. Some people say they get used to it, or something which they learn to live with over time. Okay, it's definitely considered to be, the way I see it is that snoring itself is just the tip of the iceberg. And so it's actually the precursor, or it can show that it leads to a lot of other medical consequences that we will talk about. Right, so if we actually look at OSA itself, it's actually a sleep-related breathing disorder, of which covers a wide spectrum of problems. So realistically, we have when you're asleep, there may be just normal breathing, which can come up towards having just occasional snoring, or some people who have habitual or regular snoring, which is mostly considered normal, or what we call no disease. Then past that point, you can develop upper airways resistance syndrome, which progresses on to obstructive sleep apnea, which is mild, moderate, and severe. And it's in this range on the right here where you start developing complications and signs and symptoms of the disease. Right? So how prevalent is it actually? I agree that like Dr. Betty is saying that to some degree it is underdiagnosed. I think mainly because there's a lack of knowledge and awareness about it. Actually because it's so common. Almost everybody knows a few people that happen to snore at night, I'm sure. So the prevalence estimated in North America is based on their population studies is somewhere around maybe 1/3 of men, and about 17% of women are likely to have obstructive sleep apnea in some form or the other, mild, moderate, and severe. And I think that there was also one of these community studies in Singapore where they showed the incidence of estimated moderate to severe OSA can be as high as 30% of the population. To me, seems a bit high, but I think the potential of that happening within that population, we can discuss it a little bit later. So Malaysian data, what do we have? I've actually found two separate studies. So we have one where the first one by Camille et al. Is actually a basic questionnaire-based study of 1,600 over patients in a primary care practice based on things like sleepiness indexes and symptoms, which actually showed that almost half of the patients that were seen in clinic, so that's like about 800 patients or so, actually have symptoms of snoring, of which they had notable breathing pauses by partners or themselves, and that almost the same amount also have some degree of excessive daytime sleepiness. And based on the study, the clinically suspected OSA, non-tested but suspected, was up to 8.8% of the patients that attended and 5.1% of women that attended. So to me, seems fairly high. If you told me about 8% of the whole population potentially have obstructive sleep apnea, that's actually quite serious. Then there's a separate study from Yusuf et al. And so I think this one was a thesis of from one of the master's trainees of about 289 Malaysian bus drivers who actually had sleep studies, and you can see actually 44% of them actually have obstructive sleep apnea, of which up to 6.6% of them are severe. So that's actually quite dangerous. And if you think about it, especially in things like transportation and so on, if this many patients actually have obstructive sleep apnea, there's a high risk. Well, we see a lot of motor vehicle accidents as it is.
Yes. And we talk about reckless driving, but it's actually could be possibly sleep apnea.
Yes, and I think especially in all these bus drivers, long distance drivers, you know, they run multiple shifts a day sometimes. So it really is, it can potentially be a risk, I think. Okay, so this is the data actually I found for Malaysian related studies that we have. Okay, so actually, what's the mechanism of OSA and how does it happen? So I think briefly most people understand that what happens is there's repeated episodes of upper airway obstruction during sleep. So obstructing doesn't necessarily mean a complete obstruction. It may not block fully. It can be partial, so what we call a hypopnea, or it can be a full apnea. So the hypopnea is usually, there's a criteria for it which we test for, but basically when there's a certain amount of collapse and restriction and enough to cause desaturation, yeah, so it doesn't have to be fully obstructed. So it happens multiple times a night. So as the picture shows, not just nasal breathing, sometimes from the mouth, various areas can collapse. And then it leads to disrupted sleep quality because every night, multiple times it obstructs and then patients will wake up. And so they don't get a good night's sleep. And of course, with all the snoring itself, it causes problems for the family as well. So not just the snorer, but also the family members. Most of the time, the partner, if it's loud enough, sometimes anybody else in the house. So it really depends on severity and loudness. Okay, and so as you can imagine, it's a repeated episode. So what happens is this kind of repeated multiple desaturations lead to cardiovascular complications, which we'll talk about. So briefly, this is just a picture that actually shows some like the Bernoulli principle, right? So from an area which is not obstructed, whenever it's actually for Bernoulli's principle applies to liquid medium, but it can also apply to air in this case. So over a narrowed or restricted area, so there's a higher speed through it, which lowers the pressure, of which case causes further collapse of the narrowed segment. Yeah, and so as the pressure decreases, it draws in whatever loose tissue or increases the tissue edema to the area and worsens the obstruction. And this happens multiple times during the night as the patient is sleeping.
Oh, I see. It's just not mechanical obstruction, but eventually it does cause damage to the tissue and even tissue swelling.
It does actually. There are certain chronic signs that you will notice within patients who have chronic OSA. And so they do develop some form of tissue change over time. What actually happens is when there's this kind of breathing, and when it goes through, when there's air turbulence through the narrow segment, the turbulence itself tends to vibrate the loose tissue. That's what causes the snoring sound. And so with the snoring the whole time, you can imagine, if you think about maybe those, you know, those like OSIM belts that they wear and it vibrates the body, right? So I can imagine if you wore that for maybe the whole night, 7 or 8 hours, you'd probably find it's quite painful after a while. So it loosens the tissue and then it causes worsening problems.
Sometimes it can cause some, you know, blue, black and bruises. You use it. So I see yes. Okay.
So you can develop there will be some tissue changes with this kind of chronic snoring as well, which we'll talk about later. But also we can imagine that I think in terms of things like edema and patients who maybe have problems with a bit of ischemic heart disease or a bit of renal failure, so who happen to have a bit of this kind of pitting edema. So there's some studies that show that actually when sleeping flat, because of redistribution of the edema, they will actually get a moderate amount of airway edema, which worsens the problem actually.
Oh, okay.
Yeah. So there have been some studies that show, from standing or sitting throughout the day, and then when they lie down, the redistribution actually can increase the obstruction. Right. So just a quick picture to show how it works. So when the sleep onset, so for most of us, there's some degree of pharyngeal hypotonia, which can't be avoided. The hypotonia itself leads to areas of narrowing, which causes the snoring. So like mentioned, snoring is due to tissue vibration and because of turbulence. And then the Bernoulli principle causes there to be progressive upper airway collapse as it narrows. So at some point, it will obstruct enough that you'll get an apnea or hypopnea. Yep.
Sorry, no. Do you mind if you, okay, I think she has unmute herself. Okay.
Okay.
Interrupt.
Shall I continue?
Yeah, please.
Yeah, okay. So with the apnea hypopneas, then that leads to hypoxia. So it may be something which is obvious enough where you get like a witnessed apnea, which patients or themselves may experience or family members may notice. So the classical description that family members may give is that the patient snoring will get louder up to a point where suddenly it stops. They'll go, and suddenly it's quiet. So those who have actually seen snorers before can identify very clearly. Suddenly there's a cutoff. Cutoff isn't really because there's no more snoring, there's just no more airflow, right? So without the airflow, you won't get any snoring because there's no vibration, but because it's collapsed, and so then they start to desaturate. At a certain point, the brain realizes that the desaturation is getting fairly dangerous, and then it breaks the cycle and wakes you up. So some people wake up fully. They'll describe this kind of breathlessness and choking, wake up feeling as if somebody is suffocating them, or it may just be a micro break and they'll wake up partially. So the family members or the partner may describe, they'll sort of choke or they'll sort of sigh, roll over and start snoring again, which is quite the classical description. And then it just repeats itself again and again and again. So we get periods of apnea, hypopnea, which leads to hypoxia. And then from there, they get an arousal, partial or complete. Sleep resumes, the hypotonia resumes, and then the cycle repeats itself. So we're talking about many, many times over the course of the night. Right? So like mentioned, so you have multiple episodes, desaturation, hypoxia, awakening. And so that leads to some of the main symptoms which we'll talk about, and also the complications which arise from having the disease. So you can imagine it's like being suffocated multiple times when you're sleeping, several times an hour in that sense. And the built-up amount of tissue damage from cerebral and myocardial hypoxia that you get daily for years and years sometimes. Okay, so consequences of OSA, what exactly does it cause? So the social bit we'll talk about first. And so I think this is what brings most patients in. Typically, I find that a lot of patients either come in because people have been complaining and they start to feel a bit sensitive about it, or the partner brings them in because they are fed up, usually. So the partner will say, I've had enough, I can't sleep, I'm tired all the time, do something about it. And they'll come in with the partner, which makes the consult easier because when they're asleep, they can't tell you what's happening. Or patients themselves, they may notice it or they feel very sensitive about it, and then they decide they want to come and talk to you and try to solve the problem. On measurements, actually, with an audiometer, snoring intensity can be up to 90 decibels. So like having a lawnmower right next to your ear the whole night.
Wow.
And so, yeah, up to 90. I don't think
what a description.
Yeah, well, it's based on audiometer measurings. I don't think there have been any actual studies, because what I would find interesting is that if it's up to that degree, do patients who sleep next to chronic snorers develop noise-induced hearing loss? I don't think there's any study like that. That would be quite interesting, though.
Okay.
Yeah, but actually, it's a significant disturbance, and so some of you may be nodding and think, yeah, I know exactly what you're talking about. So this kind of disrupted sleep cycle for the patients, like we said, hypoxia, they wake up, resets the airway as it opens back out, and then they snore again. So you get this kind of chronic tiredness and concentration loss. I think we're all quite aware of how chronic sleep deprivation works, right? So poor concentration, poor work performance, and actually on most studies, there's an increased risk of MVAs by about 2.6 to 3 odds ratio, or up to 3.4, right? So almost about 3 times higher risk of having an MVA compared to if you didn't have OSA. And so for workers, poor work performance, especially dangerous for manual laboring jobs, danger with using equipment or heavy equipment. And I think for children in particular, it actually translates into poor school performance. So it actually ends up labeling some of these children as, can't concentrate, difficult children, hyperactive children. And occasionally there are times where there can be this kind of misdiagnosis made when actually patients really just have obstructive sleep apnea and they're fighting hard to stay awake. That's why they can't really sit still and they can't listen to you. Okay, I'm not going to play this video because the whole thing gets recorded and put up. So we'll leave that for now. But basically it's a video which shows a driver having a micro sleep. Okay, so he's driving a bus, he actually has a micro sleep, and then he crashes into a whole bunch of slower moving vehicles and doesn't wake up until at least about the 4th or 5th vehicle. So it does happen, and I think, like we showed in the slide, where there's a high incidence potentially of bus drivers, can even be any of us, long distance driving. This kind of scene we see in the papers every now and then, right, which can happen anywhere, right? And so you do find that patients who have untreated OSA will give a history of having had some kind of MVA in the recent past. We recently saw a patient about just last week. The wife brought him in because they said that in the last 6 months, he's dozed and crashed into 3 different vehicles in the last 6 months.
Wow.
So yeah, so microsleeps actually are quite dangerous. We don't know how the actual prevalence or the incidence of it, because obviously nobody's going to admit that they fell asleep while they were driving, but probably more often than we think. And I think, considering our line of work, we probably have known some colleagues who have fallen asleep at some point in time while driving, or they've told you that they have. This is all due to chronic tiredness because of poor sleep. Okay, so the important bit to us, which of course patients, I find a lot of times they don't appreciate so well, but we need to try to get across, is the medical implication. So this kind of repeated cerebral as well as myocardial hypoxia leads to chronic tissue damage. And so based on some of the studies I've read in the past, a risk of developing ischemic heart disease, odds ratio is about 3.1 to 4.9. The relative risk of having heart failure is about 2.38. So most of the data from these studies are from patients, adults with moderate to severe OSA. Patients with mild obstructive sleep apnea have a much lower risk, but still a slightly higher than average risk of somewhere between 1 point or 1.4 or so, from what I remember. But most of the data I'm showing today is associated with moderate to severe obstructive sleep apnea. So, of course, other cardiovascular risks, not just ischemic heart disease. Stroke itself have an odds ratio of about 3.8 of having a stroke. Okay. So what's interesting, though, is that these are the ones where we actually catch. When we actually run sleep studies, in lab studies, which we monitor things like EEG and ECGs and so on. So during periods of hypoxia, we actually do see that some of these patients develop arrhythmias during the hypoxic episode. And so it's kind of curious. We do wonder how many of these patients actually go ahead and have a completed stroke or infarct when they're sleeping and so-called pass away in their sleep. We don't actually know. But potentially it's something which can happen, because we do see a lot of this kind of arrhythmias or EEG changes during periods of obstruction. So sometimes you just wake the patient up and then quickly give them some oxygen or put some CPAP.
Can I ask you something? Okay, at this point of time, we're always talking about hypoxia. Is there any evidence of carbon dioxide retention?
Yes, I think what happens is we don't test for CO2 exactly, because it's really just desaturation. But we do know that on the severe end of the scale, we have patients who have obesity hypoventilation syndrome, and so those do develop CO2 retention.
Okay, thanks.
Right. So other types of things which are associated with obstructive sleep apnea. So severe OSA patients have a 30% higher chance of developing diabetes. And all-cause mortality from severe OSA is about hazard ratio about 3. So about 3 times likely to die from any other cause. Okay. Otherwise, the cardiovascular mortality overall for severe OSA is about 5.2, and about 2 times for either having a stroke or developing a myocardial infarct if you have untreated severe obstructive sleep apnea. Right. So this comes from I took the picture from a journal which I've referenced at the back. So based on their study, the prevalence of obstructive sleep apnea, moderate to severe, in each of these categories is about stated. So in hypertensive patients, they estimate that about 50% are likely to have OSA. In congestive cardiac failure, about 25%. About 60% of stroke patients, and up to 30% of patients with acute coronary syndromes, according to this study. Yeah. So it's something that if it happens to exist, we are always interested in looking into diagnosing and treating it, because we're starting to understand that that potentially it can contribute a lot to prevention or control of the non-communicable diseases. But I think patients themselves have a long way to go in education in that sense. So are there any other medical risks potentially from having OSA? So I guess mainly whatever associated with sleep deprivation, because that leads to pro-inflammatory mediator formation, right? So there's a possible link found, not such a strong link, but supposedly severe OSA increases the risk of developing various types of cancers, less than one, somewhere in the range of 15 to 60%, depending on the study. But there's some proven risk of increased risk of having normal tension glaucoma, and as well as psoriasis or psoriatic arthritis as well in untreated obstructive sleep apnea. Mechanism, I don't really know. Just show that the link is there. Okay, right. So that covers most of the reasons why we want to diagnose and want to treat it, and things that we can try to talk to educate patients about. But we'll just quickly go over the history and other risk factors which may be associated, or how you're going to spot and diagnose these patients. Most OSA patients are probably going to come in with a history of snoring. Almost always the main complaint is going to be snoring. So from whatever it is. So like I mentioned, brought in by family, or coming on their own. If the family members bring them in, either they really find they can push them to really want to seek treatment, or you'll find that the patients themselves may try to downplay it, because it's a very sensitive topic for some people. So they'll feel like, oh, no, it's not that bad, sometimes only, or when I'm tired only, or only when I'm sleeping on my front or whatever. But it's difficult to get them to admit or come to realize that something that needs treatment. Usually helps if the family brings them in, because you get more information and more history. So typically what you want to know is obviously the frequency. Most will tell you the snoring most nights. Obviously there'll be some that tell you, oh, only when I'm very tired, only when I've had alcohol, because all those obviously causes of increased muscular hypotonia, and so that causes an increased risk in snoring. And of course some may describe it that's only in certain positions. Classically, lying supine has the highest chance of having snoring, because you get more likely your mouth will fall open, more likely the tongue will fall backwards. So AP collapse happens, anterior posterior collapse happens a lot easier. So most patients actually find that they get a bit of relief from sleeping lateral. Okay. The second most common symptom, which the patient or the family members may describe, is witnessed apnea, like how I demonstrated earlier. So either periods of quietness and then choking, sighing, self-awakening from sleep, or patients themselves actually, they can hear it. So they can hear their own snoring and it wakes them up. So any of these are likely to be snoring or witnessed apnea. And so because if they have clinically significant OSA, they're likely to have excessive daytime somnolence. So because of this kind of break in the sleep pattern, we try very hard at this point to differentiate it from true fatigue, which of course, obviously, if you don't sleep enough, shift workers, people on certain types of medication may have different or altered sleeping hours. But for the average adult, you would expect them to get about 6 to 8 hours of uninterrupted sleep. So on average, about 7 hours of uninterrupted sleep is recommended in order not to be fatigued. Anything too little, anything too much is considered no good. Yeah. So if they happen to be sleeping enough and they're still getting daytime somnolence, I'll share one of the screening tools we use later. But so classic descriptions are things like during the day, I can't stay awake. After lunch, I can't stay awake during meetings. I come home from work, I sit down to watch TV, fall asleep. Or maybe I'm sitting waiting for somebody to fall asleep. So if they're getting enough sleep and they're still falling asleep easily during the day, that's considered excessive daytime somnolence. Other additional OSA symptoms which patients may have. So a lot of them may wake up with this kind, what we call a morning headache. So kind of fogging and lack of alertness. So we wake up with this sensation that is very blurred, like, oh, you know, when you wake up in the fog and you don't know what's going on, and you kind of muddle over, switch things off. I think most of us probably have had this at some point or another. Yeah, so morning headache is a common complaint, or a morning or recurrent, this kind of sore and dry throat. It comes from mouth breathing and this kind of tissue vibration. So this kind of built up damage and vibration to the pharyngeal tissue. So the airflow and the vibration causes a lot of drying. So they may tell you, oh, I wake up multiple times at night to go and drink water, or when I wake up in the morning, it's really sore, really dry. So that's actually very common in these patients. Finally, some of them may actually have nocturia. So a slightly older men, a lot of them think maybe have BPH, or they think, oh, because my throat's very dry, I wake up and drink water a lot of times at night. But the truth is actually the mechanism behind developing nocturia is because of when they actually get an obstructive episode. So you have chest expansion against the closed airway, you get negative intrathoracic pressure, and it's the studies show that it causes atrial natriuretic peptide release. And so they get diuresis actually.
I see.
Yeah. So a lot of,
like
especially
a neurohormonal thing.
So it's the mechanism is supposed to be because of negative intrathoracic pressure, because when it obstructs, the effort of breathing goes on. So the negative pressure draws in more blood, you get atrial dilatation, and then you get ANP release. Supposed to be. So especially in older men, you want to differentiate it from actually having prostatic hypertrophy. But some of these patients, because there's a lot of overlap with things like having this kind of dry sore throat, so they'll always say, oh, no, it's because I wake up and drink water a lot. But honestly, younger patients, ladies who have no other real history, they're waking up several times in the middle of the night to go to the toilet. I think with this kind of background of snoring, it's something to consider. Okay, so that's most of the history that you'd probably get from the patient. Oh yes, so bonus bit I didn't mention here. So like I said, in children, commonly, instead of having this kind of daytime somnolence and sleepiness that adults get, children fight harder to stay awake. So they tend to be labeled as troublemakers, can't sit still, playing with things, messing things up, not listening, naughty kids sometimes. But a lot of them actually may have obstructive sleep apnea. So they will actually snore at night, very restless sleep, some of them sweating, the diaphoresis, rolling around. And I don't know about your experience, but when I was in school, from what I remember, the fat kids were always the naughtiest. Really. Yeah, that's what my recollection is actually. So
I was never fat, but I was okay.
But potentially, so it could very well be that these kids had undiagnosed obstructive sleep apnea and it wasn't really their fault, actually. And so to some degree also, there's some studies that show that actually, this talk about having ANP release. So there's supposed to be some link with nocturnal enuresis as well. So some degree of bedwetting, about 20% of bedwetting kids, based on a study, supposedly have severe obstructive sleep apnea. So something to consider in the back of the mind as well, if you do see kids who have this kind of persistent, troublesome bedwetting without anything else, who may fit an OSA kind of model. Right, so additional history that may be important. So ENT symptom-wise, obviously, because it's an upper airway issue. So patients who happen to have any kind of allergic rhinitis or sinusitis type symptoms, because natural nasal airway or nasal breathing is important. Lack of nasal breathing actually and mouth breathing predisposes to snoring and pharyngeal collapse. And of course, those labeled with so-called recurrent tonsillitis, not sure whether chicken or egg. So can be that they keep having this dry, sore throat from mouth breathing. So people think, oh, I always have tonsil infection because somebody told them they did. Or they happen to have recurrent tonsillitis and they have tonsillar hypertrophy, and then that causes some degree of obstruction. But any of this history is likely to be significant in the background of snoring. There's also some relation with acid reflux and laryngopharyngeal reflux. So those who tell you at night they get bad heartburn or wake up choking, sour taste, water brash, coughing, globus. This kind of negative pressure also draws up gastric contents and tends to be that we'll see later that the OSA patients are likely to have a higher BMI. So all of this fits in together with that kind of picture. And of course, since we know that prevalence is fairly high for these diseases, so if they happen to have any of these NCDs, then you should consider it as well. Yeah, this is the PEDS part that we talked about earlier. So hyperactivity instead of somnolence, misdiagnosis of ADHD, nocturnal enuresis, this kind of open mouth breathing kind of look, right? Kind of sort of hunched forward, neck extended, open mouth kind of posture is more suggestive that they have some kind of nasal or upper airway obstruction. So they need to keep that kind of posture in order to maintain the airway and breathe properly. Yeah, or some of them which happen to be labeled as picky eaters because nasal obstruction, large tonsils, so they can't really breathe properly from their noses. So when they eat, they can't eat and breathe at the same time. So they eat slowly, eat very little, only eat soft food or things they can quickly swallow fast. So label them as picky eaters, but potentially if they fit this kind of picture, something to think about also. You can try it yourself actually. You try and eat something and hold your breath. Can you chew the entire mouthful and swallow it? Probably not. So most of us still breathe when we're chewing. So if you happen to have this kind of nose blockage, especially in children, they can't really tell you most of the time. So they try to eat things which they can swallow fast.
But would they be able to not breathe if they're sitting up? Usually it's only when they're lying down, right?
Yeah, okay. If they happen to have very severe rhinitis or happen to have large turbinates or sometimes just this kind of small or arrested mid-facial development, then it can be bad enough that even during the day, the nose is completely blocked. Even in some adults, they're mouth breathing because the nose is completely blocked.
I see.
There's new information, more recent information nowadays that's suggestive that loss of nasal breathing and this kind of teeth contact and tongue and palate contact in children actually predisposes to the formation of, in the past, what we deem as adenoid facies, this kind of retroagnatic, narrow pinched face, which when you grow up leads to having OSA. So there's more data nowadays that suggests that restoration of nasal breathing and stopping mouth breathing actually breaks the cycle and these children grow up more normal. Okay. Okay, so I think that's a full different topic. I'm not going to talk fully about PEDS OSA this time, but we can talk about it later if anyone has any questions.
Okay.
Okay, so quickly go over some of the physical examination or some of the things that we look for in these patients. Yeah. So of course, in terms of physical examination, one of the big things we notice is the BMI. I think in most countries, BMI is positively correlated with severity of OSA. So anything more than 23 is considered fat. And of course, in Malaysia, we are the heavyweight champion. In Southeast Asia, we're heavyweight champions of obesity at 44.2% of the population, supposedly, with a BMI over 25.
44.2% of our population is overweight.
Over 25, supposedly, according to WHO, 2011.
Oh.
I was a bit surprised, but then again, I'm also a bit over 25, so I guess I'm one of the 44%.
Okay, I will not reveal my weight.
Yeah, you shouldn't ask these things.
Wow.
But yes, we know that in most studies, actually, BMI is positively correlated with severity of OSA. But it's not really just that. What we do know is that when we get fat, we don't really just put on abdominal fat, especially depending on genetics as well and racial spread. We also put on fat within our necks and also within the throat. So I'm sure some of you, when you put on weight, people say, hey, your face looks so round, because most of it comes from around here. So this kind of extra fat and pressure around the neck also predisposes to more obstruction. And whether you knew it or not, actually, your tongue and your pharynx can get fat also. So when you put on weight, your tongue gets fatter, and that also contributes to obstruction. Yes. So studies show that actually, in terms of population, Asian patients increase their AHI per point of BMI more than European or African patients. South Americans do worse, but per point of BMI increase, your AHI is likely to go up by 5.7. So you are more likely to have more severe OSA for each point of BMI higher you are compared to a white person or a black person. So more reason for us to try to control our weight more. Of course, it's not the only reason for that. So things which also contribute to it. So it's not really just a lining and a soft tissue issue. In Chinese population specifically, the facial structure is such that you're more likely to have things like retroagnathia, shorter jaw, narrower airways. And so the general box and shape itself, excluding the lining, already predisposes you to this. So some patients who have almost normal BMI will still have quite severe obstruction on actual testing. So things we look for besides the BMI, so things like this kind of retroagnathia, receding jaw. So usually you drop a line from the philtrum downwards. If the chin happens to be behind that, then typically you are considered to have some degree of retroagnathia. Okay. Patients who have short, fat, or thick necks, like this patient was about to undergo sleep surgery. So like this one, can see very short, thick, almost no neck kind of appearance, also predisposes or increases the chance of having OSA. And so like I mentioned in pediatrics, so those who happen to have this kind of open posture mouth breathing, which we're familiar with, or the classical adenoid facies, open mouth, retroagnathia, pinched face appearance. Okay, so what exactly causes the obstruction? So truth be told, anywhere from the nose, nasal cavity, downwards past the nasopharynx, into the oropharynx, and then supraglottic region. So anywhere up to about this level, before you get past the epiglottis, is likely any of the tissue there may contribute to having obstructive sleep apnea. Of course, mouth breathing is worse. We'll go over it step by step. So from the top on physical examination, the nasal part of it, so on anterior rhinoscopy, the things like inferior turbinate hypertrophy, deviated septums and nasal polyps all add to nasal obstruction, and so increase the risk of mouth breathing and having snoring. Yeah, so this is a picture with a pudicum speculum. So you can see the septum and you can see the inferior turbinate in this patient. And not actually a patient, one of my friends. Yeah, so you can see actually on this side, the septum is deviated to the right. Actually, you can see it comes out into view and it's fairly narrow. The airway is fairly narrow on this side, but it's quite open on the other. Turbinate itself also a little bit boggy and a little bit larger than I expect it to be. You expect a little bit more room, so a bit more like this, but we know the septum is deviated to the other side, so still considered perhaps a little bit hypertrophic. This is actually an endoscopic view, which shows the inside of the nasal cavity. This is the left side, this is the right side. So the left nose, septum, inferior turbinate, and this is actually a nasal polyp. So this is coming from the maxillary sinus. This is a maxillary sinus polyp. So you can see it's actually obstructing most of the nasal area on that side. On the right side, this one is actually a polyp as well, but this patient has active sinusitis. So this is sinusitis with nasal polyposis with full of mucopus. So that will also make things worse. Yeah, a lot of these there's overlap because it's all airway obstructive problems. You may say, okay, maybe you don't feel you can get a view as good as this. Not everybody has a pudicum speculum, but actually, to be honest, I think you can get a fairly good view using the otoscope as well. You don't have to push it all the way in. Just put on a fairly large speculum. You can rest it on the vestibule without pushing it past. As long as it past the hairs, you may get a view which is almost similar to this. It takes a bit of practice, but should see fairly well with that. Don't shove it all the way in because it can be quite uncomfortable. Right, so that's the nasal part. So that's back up here. So as we come down, the part that we can't view so well of it is going to be here at the back, at the postnasal space. Younger patients who have issues with allergies, mouth breathing, are likely to have large adenoids. I'll talk about that a bit later. Once you get past that point is the oral cavity. This one we can see fairly clearly. So they may have likely to have tonsillar hypertrophy. So grade 3, grade 4 kissing tonsils obviously are going to lead to further obstruction. Something else that we can look for in the patients who happen to have more bulky oral cavity, oropharynx, is this thing called tongue scalloping. So when you look at the tongue, you can see clearly that there are little teeth marks on the side of the tongue. Probably everyone's going and looking at their tongues, but it can be fairly common. So it's a sign that the tongue itself is fairly bulky, either due to fat deposition or just sometimes from chronic changes, this kind of negative pressure, you do get more edema around things like the uvula. The palate can be pulled longer due to the negative pressure, and so you get these changes also. So this also can highlights that this may be one of the areas of obstruction. because a big tongue, if you close your mouth, if it's a big tongue, more likely it will be projected posteriorly, and that will lead to collapse as well. A high Mallampati score, that means open mouth, tongue out, or what we call the Friedman tongue position, where you do the same thing with the tongue in. So if you can see the tongue is high or the palate is low, also means that more likelihood there's some degree of obstruction or crowding there. So like Mallampati, just a quick refresher, if you can see the whole tonsil, it's a 1. You can see half like this is a 2. You see soft palate is a 3, only hard palate is a 4, right? Friedman tongue position works the same way. In pediatrics, like we mentioned, this overcrowding, pinched face, dental problems, malocclusion, crooked teeth, high arch palate, all those show that there's not that much room or airway. Okay. Right. Those who have the facility and who are comfortable doing it, as part of the assessment, you can also do posterior rhinoscopy. So with the adenoid mirror, the St. Clair Thompson mirror, you can actually check the posterior nasal space for adenoid hypertrophy, or actually, and with a laryngeal mirror, you can check for lingual tonsillar hypertrophy, as well as the Cormack-Lehane grade to see if the epiglottis is retroflexed, which can also increase the risk of obstruction. So basically, the way we look at it, any area from the nose to the postnasal space, the area we call the velopharynx behind the palate, the base of tongue, all the way to the epiglottis, any or all or one or more of these areas could potentially be an area of obstruction. So as part of the assessment in patients with snoring, etc., we would like to identify them if possible. Okay. So one of the benefits of sending the patient in, obviously, is that you can get a full we can actually assess the patient fully. Typically, flexible endoscopy helps us a lot in clinic, get a true intraluminal view of where the collapse may be. Right, so this one I can play. This is one of my own videos. Yeah, so this is a flexible scope view through the right nasal cavity. You can see the septum there, and you can see the inferior turbinate. This patient came in with this is a standard history. They had some snoring, they have daytime somnolence. He has some rhinitis symptoms, nasal obstruction, worse at night, snoring often. He's woken up from choking a few times before. So you can see here that there's some degree of turbinate hypertrophy. Typically, for me, on scope, anything more than 50% of the nostril size is probably larger than it should be. And you can see this is obviously bigger. And there's some degree of septal deviation coming out that way, obstructing your view of the middle turbinate, and also a bit along the floor. So this is a postnasal space. He doesn't have very much in terms of adenoid tissue. Younger children, some adults, they have very large adenoids. It can block the entire nose, and so you may think, well, outside the turbinates all look fairly small, but the entire postnasal space is blocked by adenoid tissue, and they can't breathe because it's a posterior nasal space obstruction. But this one is quite clear. You can see that there's very minimal adenoids. So now as we come down past the area we call the velopharynx, past the postnasal space. So this is down here is the palate, and you can just about see the uvula. And then you can see actually here, this is obviously where most of the narrowing is. Lateral pharyngeal wall, the palate is low, a bit edematous, and you can see actually the lumen is very small. Once you come past the nose, this is what he's like when he's awake. So if you were asleep, probably not much hope of keeping it open. Yeah. Okay, so once we get past that point, you can see the tonsils on both sides and the base of tongue. The base of tongue itself also fairly bulky. You can see all the tonsillar, all the lymphoid tissue in the base of tongue and inside the pharynx here, the oropharynx, tonsils, base of tongue, all very bulky tissue. You can see here most of the narrowing is happening. Epiglottis itself, vocal cords, the movement is normal. I'd probably say maybe a grade 2 plus. You can just about see the cords from a neutral position. So there's some degree of retroflex of the epiglottis as well. That one, to me, what it means is he may have trouble using the CPAP, but it contributes to the obstruction. And so just to finish up, this is, yeah, so that's pretty much what I had to show now. So the left nasal cavity looks roughly the same, large turbinate, corresponding septal deviation. So you can see actually a lot of obstruction top somewhere past the palate and also down to the tongue base. These are actually fairly overweight patients as well. Okay, so besides flexible scopes and the general physical examination, there are a couple of assessment tools I recommend for use in patients whom you suspect may have obstructive sleep apnea. Both are fairly well validated and in use. So the first one is this thing called the Stop Bang questionnaire, which you can find in most places. So it's 1 point each. So stop as in snoring, loud enough to disturb others. T for tiredness, O for observed apnea, and P for hypertension. So that's stop. The bang is BMI more than 35, more than 50 years old. Neck circumference, men more than 17, women more than 16. And if the G is gender, if you happen to be male. So each one that's positive, you get 1 point. And so if you happen to have 3 or more, you have an intermediate to high risk of potentially having OSA. So it's a fairly easy screening tool which you can apply. Alternatively, you can use this thing called the Epworth Sleepiness Scale. So this is what was used in the first study I showed, which they applied it to the 1,600 or so patients in the primary care. So it's really just, it's not truly an OSA specific scale, but it's a sleepiness index. So patients who don't sleep well from anything, fatigue, insomnia, whatever, they are likely to be positive. So I would be a bit more selective about applying this screening tool. So for the Epworth Sleepiness Scale, anything more than 15, so 16 or more, you are classified as being severely tired and need to have it looked into. So each question is scored from 0 to 3. So 1, 2, 3, 4, 5, 6, 7, 8. So 20. So 8 times 3. So the maximum score is 24. So are there never or high chance of falling asleep or dozing when sitting and reading, watching TV, sitting in a meeting, inactive, passenger car in a car? Do they need to lie down and rest in the afternoon if they can? Can they fall asleep when talking to somebody? Which I have seen patients who have. They're talking to me and they just, oh, sorry, what was I saying? Oh, actually, may have experienced it before.
Boring.
Yeah, maybe I'm boring. But I've experienced it myself as well. You know, post-call, sometimes, you know, you just have to sleep. So that's why it doesn't differentiate well between having OSA and having fatigue. But patients, if applied correctly, it's useful. So the rest, of course, if you sat quietly after lunch without taking alcohol, and if you were sitting in the car in traffic. So anything more than 15 in patients who are getting enough rest potentially have OSA also. So you can apply one or both for screening in patients which you think you are not sure or you want to screen for. It's fairly quick. They can do it in the waiting area as well if you want to. Right? So that covers most of the why we need to treat and how we find these patients. So we're just going to talk quickly about investigations and a bit about treatment. We're coming down to the last bit of the talk. So in terms of investigations, obviously on our side, ENT examination, endoscopy, like I showed you, we are going to identify the levels of obstruction, rule out any other pathology. So not all area obstruction is OSA. Occasionally, patients come in, they have, recently I had a bit more snoring. Everything turns out they happen to have a space occupying some kind of mass lesion, which we don't want to miss. So it helps us to assess for this kind of hidden pathology. And also we have certain workflows for management. The gold standard, obviously, for diagnosis is going to be polysomnography or a sleep study. So if you haven't done a PSG, then you can't quite say the patient has diagnosed OSA. There are several different levels for PSG. So higher levels are more accurate. A level 1 or the gold standard best is if you hook the patient up, like in this picture, with every single lead. So chest belt, O2, EEG, EMG, EOG, leg EMG, and you put a camera and watch them. Yeah, I ask them to sleep. So it's not that easy, I think. I've not tried the full one, but even with a few wires, I don't think I can sleep. But if you have severe enough OSA, I'm sure you'll fall asleep no matter what you're wearing. But that's the gold standard. So if anything is in doubt, a level 1 study is indicated. So they do it in the lab. We monitor them, and the technician sits with the patient the whole night and watches what they do, pretty much. Level 2 is a non-observed full study. So all the same channels, but nobody watches them, nobody records them. They just sleep on their own with everything on. Almost as good. Level 3 is what actually most places offer because it is convenient and fast. What we call a partial study. Some of you may actually have the option of this with whatever vendors or whatever contacts you have. So by definition, a partial study needs to have at least 4 channels of measurement. And then they have proxy calculations which sort of work up towards maybe this is what the score is like. So it is helpful and it's fast, but it's definitely not going to be as accurate as doing a full study. And of course, level 4, you have what you call just overnight oximetry. Put on some SpO2 monitor, sleep one night, and then we look at it. It's not considered diagnostic. is probably just slightly better than one of those smartwatch apps which you switch on and say, oh, I had a good night's sleep. So useful to maybe give you an idea, but you really at least want to have a level 3 partial study or upwards. When we look at PSGs, just to quickly go over, if you happen to have a PSG that comes to you, what we're looking for really as a minimum is the AHI, which is the apnea hypopnea index, which is scored per hour. So this is the number of times the patient has an obstruction with desaturation or hypoventilation per hour. So for an adult, less than 5 per hour is normal. You have mild OSA, we have 5 to 15, moderate 15 to 30 episodes. More than 30 episodes per hour is severe. Surprisingly, a lot of patients have higher. We've seen some 50, 60 episodes. So that means almost every minute they are obstructing and desaturating, which sounds pretty bad, but they've lived like that for quite a few years, I think. Past the AHIs, we look a little bit at this thing called the saturation nadir, which is how low the recordable SpO2 gets. So usually it's a good indicator to give you an idea, a ballpark figure, how chronic and how severe it is. Some patients, it can be quite scary when you look at the result. They can desaturate to like low 60s. If that happened in the OT room, I'm sure the anesthetist would have a heart attack. So at home, like I said, we don't know which of these patients actually go on not to wake up. So potentially it can happen. Anybody desaturated to 60-something%, there's a good chance they may not wake up, I suspect. So these need to be looked into and treated a lot faster because you never know when they have a completed event. And also sleep efficiency. Like I mentioned, the percentage of recordable time is important. If you wore it but you couldn't sleep, then you have no data. Very roughly, that's what we look for. The full studies give us a lot more stuff. So things like REM versus non-REM sleep, arrhythmias, chain strokes, central apneas, positional data, EEG, and true sleep patterns. So a lot of the more technical stuff, which is important for complex cases. Of course, full PSGs are expensive. They're uncomfortable. If I'm not wrong, if you want to do a full in-lab study, we're looking at 1,000-something ringgit, I believe, because you need a tech to sit in with them, and then they need to wear everything else. So partials are the advantage. Obviously, full has a lot more data. Gold standard, but it's expensive and not so comfortable. Partials can be done fairly quickly. Most of them is just a belt SpO2. There's some kind of nose lead or mic sometimes, depending on the machine. More comfortable. It tends to underestimate the severity by quite a large margin. You may get false negatives. So despite the symptoms and everything, it comes out AHI is normal, which seems impossible. So I think generally for young patients, uncomplicated patients, it's an option, but be ready that you may get a few of these sort of ambivalent, not quite sure whether positive or not kind of cases, to be honest. Okay, so honestly, like we said, once you've done the PSG, we have a diagnosis, then comes the treatment. Broadly speaking, the objective for treatment is we want to prevent airway collapse, yeah, and you get restful physiological sleep. Main options are going to be CPAP, which is the gold standard, surgery in some cases, and there's some adjuncts and supportive measures which can help. So the gold standard of treatment for OSA is still CPAP, continuous airway pressure. And so what it is a pneumatic splint. So they wear the machine. It forces air, not oxygen, just air in, so that there's enough to spin open the airway at enough pressure so it doesn't collapse and they don't obstruct. So well, when you use it properly, CPAP will normalize the AHI. We can get it down to like point something or 1 or less when used well. Surgery not required in most situations. Of course, disadvantages is that some people can't stand the stigma of wearing a machine every night. They say, oh, not for me. People laugh at me. I can't carry it around. Of course, machines, a study from Korea when I was there, they showed that the compliance rate of patients who were prescribed CPAP was only about 50%. So majority of patients after 6 months to a year, only 50% of patients continue to use it. So issues with comfort. And in Malaysia, actually, the machine itself is about 7,000 ringgit. So this one is paid out of pocket for patients if they want it. Then, of course, you need to use it every night. Nights you don't use it, you're going to have OSA. So usually we offer a CPAP trial. We'll loan them the machine 1 to 2 weeks for free to try to see whether or not they're used to it, whether they benefit from it. The different masks which we fit on. So patients without any nasal pathology, actually the nasal mask or the nasal pillow works very well. They feel it's fairly comfortable. Those which find that it's a bit fiddly or find that occasionally they get some nasal obstruction which they don't want to have anything done for, they may opt for a full face mask. So this is usually personal choice. Then if it fits well, they decide to buy it. Then it's just daily usage, and the usage data and the pressure data, etc., and the AHI is all stored for up to 3 months. And so typically I'll follow them up 3 monthly in an OSA clinic. So surgery, usually if it comes down to surgery, it's multi-level. So we'll do multi-level surgery to address the areas which collapse. So scope and so on help us to decide. So main levels, either the nasal cavity, velopharynx and oropharynx, base of tongue and epiglottis, which is the more dangerous and the more difficult surgery usually. So it's very highly customized depending on the patient and depending on level of obstruction. And it's not one size fits all. Everybody gets sinus septum turbinate tonsils. You probably won't cure much, except for, you won't cure much in that kind of situation. So it really is a patient by patient basis. How does surgery help? It can be helpful in patients where you identify the area of obstruction well. It means that you don't have to use CPAP if done properly. Younger patients, there's less stigma because they don't have to wear the machine and seem dependent on it. These are just some pictures of a couple of one of my patients. So the top picture is a pre-septum and turbinate picture. So you can see the septum in the middle, some degree of right-sided deviation. You can see a large turbinate compressing against the septum. And this is actually 1 week post-op septoplasty and turbinoplasty. You can see there's still a scar there as the mucosa heals, but I can see actually a lot clearer, and they had no real problems with the nasal breathing after that. I also did the palate. I don't have a picture of that because it's taken from a straight camera, but he got much better. And then with enough exercise, actually his AHI normalized. But the palate work is something similar to this picture at the bottom, the pharyngoplasty. So we remove the tonsils, we tighten the palate, and we stitch it up to hold it in place. Problems with doing surgery, of course, is that the efficacy can decrease over time, either poor selection or due to patient age as well. So as you get older, you tend to put on more weight, you have more loose tissue. Some patients, the AHI will creep back up. And of course, it means you need to have surgery under GA. There's a risk of bleeding. It's not really clear-cut, but most of the time I recommend for those who can, CPAP trial first. If they really don't like it or it doesn't work out so well, they may need surgery. Sometimes they need both. The patients who have a lot of crowding, like in the scope I showed earlier, even if he could use a CPAP, he may find pressures are too high and very uncomfortable. So surgery to relieve the amount of pressure required makes it much more compliant for the patients. Or some patients, after initial surgery, 5-6 years down the line, they find that actually they put on more weight due to stress, whatever, and then they may need CPAP. So it's not really fully completely one or the other. Okay, so very quickly, just cover some adjuncts. So other things that can help to in the treatment of OSA are not usually used as standalone treatments, but can help. I usually recommend sleep hygiene. Like I said, good uninterrupted sleep, 6 to 8 hours, regular hours. No caffeine or alcohol after 2 p.m. because it's a stimulant and it can alter your REM sleep patterns. Daytime, enough sunlight to regulate melatonin production. Light exercise about 30 minutes 3 times a week, but not just before sleeping, obviously. Stop smoking, and lateral sleep tends to be more helpful. Some oral appliances may be helpful if the area of obstruction is purely tongue-based. So you may have seen some of these around, a mandibular advancement device which pulls the lower jaw forward like that. Patients may complain of problems with drooling, or that they may find their teeth shift over time because it's pulling on the teeth. But for some patients, it works well. Or this thing called a tongue retaining device at the bottom here, where you sort of like suction your tongue into the device and sleep with it like that. With the tongue protruding forward, it doesn't collapse into the base of tongue doesn't collapse into the airway, and so it helps some patients as well. But as I said, only if it has a base of tongue obstruction with nothing else. Other things, you may want to look this up if you're interested, this thing called myofunctional therapy. So a bit of like physiotherapy for the pharynx. So in some studies, up to 50% AHI reduction can be achieved from this kind of thing. So it's like tightening all the muscles, but it can't be used on its own. Weight losses and good sleep hygiene also contribute to this. And so the evidence is fairly new, but we're getting more of it over time. And of course, weight control, aim for BMI less than 23. Difficult if you have OSA. If you don't sleep, you can't exercise well, and this kind of stress response makes you feel like eating more and you put on more weight. But like I said, normal BMI patients also can have OSA because of skeletal structure abnormalities, especially Chinese patients. Indian patients, mostly nasal because they happen to have a longer, taller nose, but the rest of it not so much. Chinese patients, a lot of time they have a lot of crowding, teeth, small jaw, that kind of thing, more genetics. Mouth breathers, and also actually now we know that it's not just obstruction, issues with neuromuscular coordination and posture. That's a talk for another day. And so that's pretty much it. So in summary, I do think that OSA is a fairly underdiagnosed and undertreated condition. Most people believe that snoring is natural and it's not bad enough that you have to care about it. We know now there's a good evidence of data that shows that untreated moderate to severe OSA increases the risk of developing NCDs or worsens them. Treatment is highly patient dependent, but requires some degree of maintenance. So those are my references. And thank you. If you have any pressing questions or you have anything you want to call me about or discuss about regarding ENT patients, OSA or otherwise, you can get in touch.
Oh, very good. I really enjoyed the talk.
Oh,
So
thank you.
is there any questions, please?
Yeah, any burning questions anybody has to ask? If not, you can also contact me
They also
if
want,
need
of
be.
course, this other thing that they want from me. So I need to share. Hold on, I'm going to share it soon. Okay. Please key in your questions, or you can even ask us questions.
Yeah.
Okay, let me try to, can you stop sharing and see?
Sure.
Because I need to share. Okay, let's see. Because I need to share my, hold on. I'm not sure how to share now. Sorry about this. Okay, let me just go to this. Oh, it was here just a minute ago. So sorry, yeah. Okay, so, okay. Now, hold on, I'm quite a noob. So, some people just want to enter now so that they can get that CPD point. Okay, is there no questions at all?
Okay, there's a question here in the chat box, whether there's any role of BiPAP in OSA. Yes, there can be. So in some cases of severe OSA or in this kind of obesity hypoventilation syndromes, actually you can't really get, if you see continuous pressure, it is probably not going to be sufficient for the patient because they require a lot of positive pressure to maintain the airway open. So in that case, BiPAP has a role. So you have an EPAP and an IPAP. So the EPAP in order to keep the IPAP in order to keep airway open, the EPAP so they can breathe out. If it was CPAP alone, then the pressure is continuous, and then especially at higher pressures, those patients will find that they feel like they're suffocating because they can't exhale. It just keeps pushing it in. Okay, there's another one here. Can a GP order?
Yeah, can you?
Sorry, Dr. Betty. Yes.
Sorry, just call me Betty will do. Can a GP order a partial PSG without ENT referral?
I guess to order the PSG is not an issue. I do think that nowadays there are a lot of there are a lot of the companies that are coming out to sort of give more treatment and investigation options. I don't really have an issue with it, but I guess the problem comes with the assessment and reading of the PSG, like I showed in the previous slide. So partials alone, without knowing, looking at the rest of the parameters, there's a good chance we underestimate the disease or not quite sure how to treat it. Not all patients need or would want CPAP, so I think ordering is not really an issue. But if you feel like
interpretation is the problem.
Your interpretation is probably best done by somebody who's sleep trained.
Yeah, it's not an easy. How do you actually assess hypopnea during sleep study? I mean, saturation is easy, but is it from observation of a technician?
So for partial studies, because you don't have all the channels, they will follow a calculation, and a proxy calculation. So that's why if you look at it, they have this. They actually separate between. They don't put RDI, so RI and AHI. So they actually use a proxy calculation to come up with what potentially is a hypopnea. So it is like it may not be as accurate. So a full sleep study, so based on criteria, you need to have a desaturation more than 4% for 10 seconds or more, or which causes an arousal, which that one you can only catch on a full PSG.
Okay, Andre has a question. Andre is
Mhm.
actually a surgeon.
Mm.
Andre says, what
Oh,
is about,
Mr. Das. Hi, Mr. Das.
oh, you know Andre. Okay,
Yeah.
what about physical mouth aid like mouth guard? Okay.
Okay, neck brace. I don't think the posture itself, neck braces and so on, I don't think there's any good evidence to show that it works, because what you really want is you want to improve the intraluminal size and prevent the collapse. Mouth guards can prevent bruxism to protect the teeth. Bruxism also can be an early sign of, or a mild sign of OSA in some new studies. But like I showed, you really want something which increases the airway if in the areas which you know it's narrowed. So mandibular advancement devices, this kind of tongue retaining devices may help for patients who have base of tongue obstruction, but just guards alone and mouth brace, no, there's no evidence that it helps.
Okay, we have some questions from actually Facebook. Zian Lim asked, since those who fail surgery may need a CPAP, would they be able to benefit from a second surgery?
Potentially. So like I said, surgery is very highly customized, and there are various levels of how severe the surgery needs to be. Well, not severe, how radical the surgery needs to be. So like some of the examples I've shown where we clear the intraluminal tissue, so septums, turbinates, adenoids, tonsils, palate work, base of tongue work. But by and large, those that fail that, and you can identify the obstruction after that, or just a general failure where the whole thing is narrow, the actual so-called gold standard, which works best, is actually what I call a maxillary mandibular advancement, a little bit more invasive. So actually, they sort of do a Le Fort one, and then they pull the entire thing forward like that, so that it opens the airway straight away. Slightly larger, but that has shown to work very, very well, actually, if patients are agreeable.
Okay, I just take one more question from the Facebook. Ken Yong asked, may I ask if obesity is the only cause of OSA?
No, it's not. So like I showed earlier, obesity contributes a large proportion to development and severity of OSA, but really any kind of airway obstruction. So obese patients obviously have it worse, but patients who happen to have nasal pathology, polyps, turbinates, septum, enlarged tonsils, any kind of airway obstruction in these areas can predispose to having OSA. You don't have to be obese to have OSA. Of course, you're more likely to have it. Symptoms are likely to be worse. Severity is likely to be worse. But slim patients who happen to have this kind of narrow skeletal structure, or happen to have very severe sinusitis, allergic rhinitis, and adenotonsillar hypertrophy, are also likely to potentially have OSA.
Okay, so her next part of the question is, if this patient then returns to normal BMI, will the OSA be something that is reversible?
Potentially. I think at the end of the day, you'll have to do the sleep study again and see. So if you don't have any other predisposing factors, you can't identify an obvious area of obstruction, or one where you have patients who are very motivated, then when they come back to normal BMI, you just retest them and see if it comes back negative. I did have a patient that if I had time, I wanted to share some case studies, but he was actually fairly overweight. He was a sportsman in school. Then he took some time off, started work like most of us. We don't exercise, put on weight, and then he started developing OSA. So he had a little bit of allergic rhinitis from young, and so he agreed that he didn't want the CPAP. So we said, okay. He didn't feel like he could exercise properly because he was still too tired all the time. So he agreed that he would get better sleep. We did the septum, the turbinate, the tonsil, and the palate. And then after that, he managed to get enough sleep. He exercised. His BMI came down to about 26 from about 34, actually. And actually, his AHI normalized. So in those patients, if they're able to maintain it and they're disciplined enough, I think that a period of weight loss is possible, but it's difficult. Like I mentioned in the talk, if you're not sleeping well at night, how many of us can actually get in enough energy to exercise properly?
Okay, Lily asked, how about
breathe right strips? Okay, yeah, the one which you stick across the nose here, isn't it? Breathe right strips. The way a breathe right strip works is that you tape it across the nose to prevent nasal valve collapse. For some people, if you breathe in hard from your nose, you'll notice maybe the sides kind of collapse and fall in a little bit. So breathe right strip pulls this aside and holds it open. It's not likely to be the only reason for you to snore. So it's a very limited use. It may work if you obviously only have nasal valve collapse, but it's not going to cure the problem, no.
So iPad, okay, this Dr. iPad.
Yeah, normalized AHI, does it mean OSA is reversible? Well, it is treatable. It's treatable, but I think it's something to be thought about more along the lines of a chronic disease. I wouldn't say it's really, well, curable in the ones where surgery helps to reverse it. But, you know, as I mentioned before, some of them, AHI creeps back up over time. So is it treatable? Yes, it definitely is, and we should be treating it because we can appreciate that there's a lot of preventable diseases from treating OSA.
Okay, can I ask whether have you ever referred any patients, okay, with OSA for bariatric surgery?
Yes, the ones which happen to be obese, they would benefit from it. I think that one also depends on a lot of patients. I find some patients, they are very keen on it. Some of them are completely the opposite way, and they're very sensitive. Like, no, you know, I know I can settle this myself. I can exercise. I can do it. But there have been one or two that have been quite keen to go and do.
Yeah, I have had patients that I've referred for, and I tell you, it is the most, you know, it's so satisfying to see them lose weight, and it feels so happy and so grateful, even though I didn't do the surgery. The fact is that I just signed the paper to refer. They were so grateful, and I really think that, yes, I think bariatric surgery is
yes, I think it's very helpful, especially in the ones which are, especially if you're talking about really obese, overweight patients. Yes. Honestly, I'm not going to GA them to do an airway procedure if they're that obese, to be honest. It's probably not going to help much. And most of these patients, the AHI is probably extremely high. It's about 50, 60 sometimes. So even if I did the surgery, minus 40, you're still sort of like borderline severe. So to be honest, bariatric surgery probably works better, plus CPAP. And then after that, we see how.
How do you actually operate on this patient, especially the posterior nasal?
Endoscopically.
And while it's being intubated, right?
Yes. So, tonsils and palate work is just like how we traditionally do tonsils. So the tube goes in the center, mouth gag, and we do the palate and the tonsils. Most of the postnasal space and nasal work is all endoscopic nowadays. So, like I showed the picture of the scope just now. So everything through that.
I see. So really, quite like a small space and quite a lot of tubes going in at one go.
Yeah, to some degree.
Yeah, to some degree. Okay, if there's no more questions, can I ask whether everybody has got their CPD points? Any problem with scanning this QR code? I've tried it myself. You can actually do it yourself, Liew.
Oh, okay. Let's give that a try.
Get the point.
Try.
On top of the 5 points that you're going to get as a speaker.
Oh, okay.
Yeah.
Right. So, okay, let me get that open.
Okay, I hope you got Liew's email or his mobile.
Okay. Yeah. If you can't contact me on those, you can always contact me via Beacon Hospital as well.
Yeah, or you can always get him through me. Do join us on our medical forum, which is the Beating Hearts Medical Forum. Selena says she can't scan. Sean also said he can't scan. Okay.
I'm going to give it a try now.
Okay. Are you watching it through your handphone? If you're watching it through the handphone, you can't scan through the handphone. You have to watch it through your laptop or your... Okay. And then scan it with your handphone. You're watching it through the iPad, then you have to use your handphone to scan it. I have no problem scanning it. You can't, so many people can't seem to.
I managed to scan it just now, but I'm using it on my laptop and I scanned it from my phone.
That's right. Can you try again? Okay, what you do is, okay, can you see this? You go to the MMA event Okay. Hold on, it's a bit slow. Okay, just below this bar, the scan QR, click on this scan QR, and then this will come out, and then scan on it. Okay, use MMA event scanner. So, okay, if you can't, then what you do is you email me, and then I will get the personnel, the marketing personnel in Beacon to actually get for you the points. Point, only one. Okay. So next week, we're coming back with another webinar. And I think next week is actually with Dr. Ong, who's an ophthalmologist, if I'm not mistaken. Yes. So we're going to talk about eyelid disorders. And we will also give one MMA, one CPD point. And all these people coming in just only to get the CPD points. I'm not going to let them in anymore. Okay.
Okay. Yeah. Well. Okay. Thanks, Betty, for
Thanks,
having
Liew.
me. Yeah.
Yeah,
And
I
so,
think it was really very good. It was really very good. And thanks for keeping to time. And see you guys. Bye, guys.
Okay. Thanks, everybody. So, anybody wants to collaborate, or if any referrals or you need to discuss, just get in touch lah. Anytime.
Yes, that's right.
Okay. All right.
Anytime.
Thank you.
Okay, bye. Okay, see you guys.
Okay.
Bye, Liew.
Okay. Bye, Betty.
Yeah, hold on. Let me